Thank you, and welcome everybody. My name is Frank Mitchkay. I'm the Vice President for Public Policy and External Relations for the National Committee for Quality Assurance, or NCQA. NCQA has had the privilege of convening, along with the American Telemedicine Association and the Alliance for Connected Care, the Taskforce on Telehealth Policy. Taskforce membership includes healthcare leaders from across the country, and today you'll hear from them on the findings and recommendations that they came together and agreed to in consensus on the future of telehealth policy. Before we hear from our members, I'll provide some background on how the group came together, how they reached the broad consensus outlined in the report, and I'll highlight the high-level takeaways. Let me start with the charge that was put to the task force. The charge was to evaluate the rapid transition to telehealth during COVID-19. 6 months ago, as the world was turned upside down by the outbreak of COVID-19, and frontline healthcare workers scrambled frontline healthcare workers were putting their lives on the line to treat the earliest victims. The ambulatory care side of the world effectively closed its doors. In many cases, the only way to receive non-emergency care for hundreds of millions of Americans became via telehealth. State and federal governments suspended sometimes decade-old restrictions on who, where, and when remote care could be provided, and the floodgates were open. The historic increase in usage offered a real-time case study on the effects of virtually unfettered access to telehealth. The task force came together to assess the earliest results, understand the opportunities and challenges that this crisis identified, and make recommendations on how to maximize the former and mitigate the latter. Subgroups were formed to focus on 3 priority areas: patient safety and program integrity, data flow, care coordination, and quality measures, and the impact on total cost of care. These groups met throughout the summer to share their own experience with telehealth before and during the pandemic, and to develop their findings and recommendations on the best way forward for telehealth policy. Here's a list of the task force members. We are incredibly grateful for the time and effort that these very busy individuals carved out from their day jobs and their summers to contribute to this effort. Let me start by reviewing the top line findings, and then I'll hand off to our conveners to describe the findings from each of their subgroups. The first of the findings was that telehealth is healthcare's natural evolution into the digital age, not another type of care. The way I would couch this is to say that just as retail sales have evolved to the Amazon model, and ATMs have become the main interaction point for those who are seeking to do their banking and get access to their cash, telehealth is a natural evolution that the technology now allows and that will make access to care easier, as well as allow for folks who otherwise may not have been able to get their care in person, either under pandemic circumstances or others, to get that care. It can be a critical tool in advancing a well-coordinated, patient-centered, value-optimized healthcare system. And we've seen that both before the pandemic, but in particular during the pandemic. Finally, the flexibilities that were created when the restrictions on telehealth were lifted due to COVID-19 have generated new evidence and adaptations that question some of those restrictions, many of them, we would say, and the report says. And they were imposed at a time when technology was less mature and use cases more limited. And that's the exciting part of the experiment we've been undergoing for the last 6 months. We have new use cases, we have new data, we have certainly plenty of anecdotal evidence, and that was part of the charge for this group, was to analyze that evidence and come up with recommendations on the future for telehealth policy. So with that, let me hand off to Krista Drobak. She is the Executive Director of the Alliance for Connected Care, and she oversaw the deliberations of the subgroup charged with assessing the impact on total cost of care. Krista?
Thank you, Frank. Thank you to NCQA and ATA, our partners in this effort, and to all of the dedicated members of the task force. And I also want to recognize Chris Adamek with the Alliance for Connected Care, who worked hard on this as well. The Alliance is an advocacy organization dedicated to telehealth and remote monitoring. So we were always the ones that wanted to see the rosy picture of the data coming out of the total cost of care subgroup, but we had a very diverse group, which we were excited about. We had representatives from urban areas, rural areas, health systems, ACOs, physician groups. So it was a good mix of perspectives, and we got down to business really defining what is it that we want to talk about related to cost of care. And, you know, when we talk about cost, we often talk about value. And, you know, the value equation is really cost plus quality. And, you know, we figured we've got a really great quality group also working on this project. So we just honed in on, you know, where can we save money essentially? And what does adding telehealth mean for taxpayers if we add it to Medicare, for example? So we set about mainly starting with the assumptions about telehealth and trying to ascertain if those assumptions were correct now that we actually had some data. So some of the information that we started talking about was based on anecdotal evidence, and we tried as much as possible to get real data. But I'm sure, as all of you know, extracting data, especially in real time, it can be very time consuming. But on our first point with substitution of care, is telehealth a substitution for in-person care, or is it an add-on? In that particular instance, we were able to get data from 20 entities, a mix of health systems and mid-level physician groups and ACOs. And it basically showed that the level of utilization stayed the same over the course of the early part of the pandemic and shortly after the reopening. So the mix of whether patients use telehealth or in-person care changed, but the overall utilization of care stayed pretty steady. So we don't want to say that there's a total substitution effect just because it's very early, and more data needs to be collected over time. And you know, we plan on continuing to do that, but we were very pleased that we didn't necessarily see a spike in utilization when you make it easy for people to access their physicians and other providers. So we also looked at readmissions. That's a pain point for the healthcare system writ large, and can we reduce readmissions? Anecdotally, we learned that some of the two transition codes after you leave the hospital were being billed at higher rates, which indicated to us that there might be an increase in utilization of transition care management, which could reduce readmissions. Obviously, need to look into that further as well. And then non-adherence to care plans is another pain point in the healthcare system. So we looked at level of missed appointments. And we did get some limited data that appointments were being kept more often using telehealth, which I guess makes intuitive sense. And our contention is that if people are not missing appointments as often, they're better adhering to a care plan and could potentially have better outcomes and lower costs as a result of that. And then finally, we looked at skilled nursing facilities transfers. Oftentimes when patients have complications in a skilled nursing facility, they get transferred to the hospital and you incur an ambulance fee and an ER fee and potentially inpatient hospitalization. And we were able to get some limited data again that showed that hospital transfers went way down, and that telehealth helped solve some of the problems that were impacting nursing home residents without needing a transfer. So we thought maybe that could be another area where we could save, where telehealth could actually save money in the cost of care. So that's the broad overview. I encourage you all to obviously read the whole report with the in our section. And if you want to provide data in your experience in your physician practice or health system, we'd love to continue collecting that data, especially as we seek to inform policymakers of what has happened during this time period. But I will turn it over to one of our esteemed subgroup members, Carrie Palikanis. She is the Executive Director of Connect Care Operations at Intermountain Healthcare and has been an enthusiastic supporter of educating policymakers and helping to really push the ball forward on connected care. So I'll turn it over to Carrie.
Thanks, Krista. I appreciate it. And I just wanted to take some of the points you pointed out and highlight them a little. I think one of the best parts of this task force was the ability for so many health systems to be able to share that data and kind of reaffirm where we are with our beliefs associated with telehealth. The number one key that I push home to everyone, and I think again is important here, is the understanding that telehealth is a change in delivery modality. It's not a different type of care. And so frequently policymakers look at it as a different manner of care versus what it truly is a different modality. And therefore, telehealth needs to be reimbursed based on value, just like we are doing with the cost of care delivery as it is in person. We need to have a flexibility on reimbursement so that we can maximize the benefit of patients and the systems at large. And we also need to understand that what we often view as new costs associated with telehealth are probably baked in already into in-person visit costs. And so there's a lot of assumptions that are made about telehealth costs that are just that, they're assumptions. What we've done at this task force and what I'm really proud of is that we can actually take data from the pandemic and really compare it across the country and across systems. And so there's recurrent themes that we've found. One is that during the pandemic, while we did have a reduction in inpatient visits, we had a subsequent increase in telehealth visits, but we never had a net value of visits that went above pre-pandemic levels. And so it really is substantive rather than additive. And that's a concern that constantly comes up, that telehealth is going to increase costs because there'll be more visits associated with it. We didn't see that in the pandemic. And we kind of expect that we're not going to see that again post-pandemic either, because one of the things that we've seen as well is that not post-pandemic, but as the initial surge dropped off, 30% of our visits went back to inpatient visits, and 70% of the visits went back to inpatient, and the remaining 30% remained as telehealth, but still no net increase in the number of visits. Obviously, we need to do some further analysis over time, and that's kind of one of the most important things we're asking for from the policymakers is, give us the opportunity to look at this in the post-pandemic new normal environment and let us see if we can continue along the same data modalities to look at how we have utilized the services effectively. Preventing more costly care is something that, again, those of us in the telehealth world talk about all of the time. Ascension and Nemours had almost identical responses in their patient response to what would they have done had telehealth not been available. 70% of those patients said they would have gone to an ED or an urgent care, which obviously would have been a more costly level of care. We want to incorporate costs to the family and caregivers when we're talking about cost savings associated with telehealth. We don't just talk about the replication of the cost and the E&M code. We need to look at things like avoiding transportation costs for patients and family members, time spent scheduling or waiting for a visit, missed work for patients or caregivers, childcare, elder care, missed appointments, and the technology and infrastructure costs associated with telehealth visits. And when we look at that, we've done this at Intermountain with our virtual urgent care, we've really been able to come up with what we call a system value associated with telehealth use, instead of just looking at the billable costs associated with telehealth. And we've shown an incredible value-based response to telehealth use. And that's one of the reasons why at Intermountain, we have supported and increased our vision associated with telehealth. And then the transitional care, yes, that also goes without saying. Also, when we're looking at SNFs, looking at reduction in readmissions, and we're looking at now, of course, the new call for evaluation of SNF-related infections. That's something that can easily be managed through telehealth and really can be managed at a lower cost than moving patients back and forth. So I think overall we've shown in the task force results that there's value that's been developed through COVID data, but we do need, and we should develop more work towards the evaluation of telehealth. But I think the key to take home is that we can't use assumptions about telehealth. We really need to use facts, and we need to look at the data as it's presented to us and continue along that way. And that's going to give us the best outcome, because we won't know the value of telehealth until it's available to everyone.
Thank you, Carrie and Krista, and thanks for all your work on the subgroup. Next, we'll turn to Ann Mon Johnson. She's the CEO of the American Telemedicine Association, which oversaw the work of the subgroup on patient safety and program integrity. Ann, thanks for joining us.
There we go. Thank you. And thank you everyone for being on the line. On behalf of the ATA's board and membership, I'm proud to have the ATA co-convene along with the Alliance and NCQA, this amazing group of thought leaders. I want to commend each of them for their hard work on developing consensus-based telehealth recommendations that policymakers can use to set health policy that will benefit all Americans. I also want to thank those in Congress, especially our telehealth champions, and in the administration that put in place modifications enabling the needed adoption of telehealth. I'm confident the recommendations we offer today will help inform your work in ensuring we make these changes permanent. We've all seen that telehealth can support access to safe, appropriate, and cost-effective care. The ATA is the longest standing organization representing a diverse membership that is driving evidence-based telehealth care with practice guidelines, policy, and education. Consequently, I'm delighted to highlight some key recommendations from our group on patient safety and program integrity. First, the goal for patient safety in a telehealth or in-person care encounter is the same. Care provided must not result in preventable patient harm or mortality. Telehealth can enhance patient safety by preventing care delays, reducing exposure to pathogens, and minimizing travel needed for in-person care. Policymakers should fund research on telehealth best practices for patient safety. Speaking to program integrity, while it is undoubtedly important to vigorously protect against fraud, waste, and abuse throughout healthcare, including in telehealth, arbitrary telehealth restrictions are not a justifiable or a viable program integrity strategy. The most effective approach to aggressively fighting fraud, waste, and abuse for both in-person and telehealth care is to leverage sophisticated technology tools such as AI that can detect aberrations, enhance existing program integrity enforcement efforts, and also to drive better collaboration with healthcare stakeholders. And now I'd like to introduce Dr. Nancy Jin, Executive Vice President and Chief Quality Officer of the Permanente Federation. In this role, she leads the quality efforts for the Permanente medical groups that provide the medical care for Kaiser Permanente. Nancy was one of 8 incredibly engaged and thoughtful experts that participated in this subgroup's work. Nancy, the mic is yours.
Thank you so much, Anne. As you noted, Kaiser Permanente is an integrated system that owns the entirety of the care experience for our patients, from ambulatory to inpatient and long-term care. We had already been on a journey of expansion of telehealth offerings BC before COVID, but those efforts accelerated rapidly, as everyone's did, with the advent of the pandemic. It really has been an honor to participate in this effort and bring our group into the conversations with leaders that represent not only the best in healthcare, but representing some of the more vulnerable populations in our country, all coming together with the collective purpose of achieving consistent excellence in quality, safety, and integrity in telehealth. I want to thank, first of all, my fellow work group members who included representatives from such august groups as AARP, AHIP, the National Council for Behavioral Health, Stanford, and Teladoc. To work with such deliberate, disciplined, knowledgeable individuals in this shared endeavor has really been a privilege and a joy. Many thanks also to the hundreds of people who participated in our listening sessions and shared their knowledge through public comments periods. Their keen insights and lived experiences were immensely helpful to the work group and informed our work and our efforts significantly. So herewith are the highlights of our work group's 5 patient safety recommendations and 3 program integrity recommendations. So for patient safety, number 1, policymakers should partner with clinical subject matter experts to identify and recommend minimum standards for assessing and ensuring patient safety via telehealth care delivery, and integrate those recommendations into existing safety standards. Number 2, policymakers should integrate patient safety standards for both in-person and telehealth care across policy, adapting and supplementing existing safety policy standards if needed. Number 3, Congress should continue funding AHRQ and other research efforts to identify what works or what doesn't work in advancing telehealth patient safety. 4, policymakers should update existing policy for in-person care-related adverse patient safety events and incorporate those into telehealth, leveraging the work of patient safety organizations to achieve optimal impact. 5, policymakers should carefully evaluate the experience of allowing prescription of controlled substances via telehealth during the pandemic, particularly for medication-assisted treatment of substance abuse disorders, and how continuing this policy can be done in a manner that protects patient safety and prevents overprescribing or abuse. Now let's turn to the work group's program integrity recommendations. Number 1, Congress should direct and fund enforcement agencies to harness available and emerging technologies. For example, under the existing healthcare fraud and abuse control program, the Health and Human Services Inspector General and CMS already have extensive program integrity policies and procedures in place that could be applied to telehealth care. But the agencies tasked with protecting Medicare and other health programs must be resourced to maximize the effectiveness of AI, artificial intelligence, and existing digital forensic tools and strategies to identify and mitigate fraud, waste, and abuse. And policymakers must protect patient privacy in every telehealth fraud, waste, and abuse mitigation effort. 2, Congress does not currently need to create new programs to address telehealth fraud, waste, and abuse, but instead should require HHS to integrate telehealth into existing fraud, waste, and abuse efforts. For instance, HHS already has a system to mitigate telemarketing-oriented durable medical equipment fraud. We need HHS to continue to use existing groups to develop and enhance other telehealth fraud, waste, and abuse detection systems. And Health and Human Services should provide guidance on the application of newly integrated policies to help payers, clinicians, and other providers understand and comply. And finally, HHS should closely monitor fraud reports to the Inspector General related to telehealth and examine further ways to deter traditional fraud if there is evidence that telehealth accelerates it. So this concludes the recommendations of the Patient Safety and Program Integrity Work Group. Thank you so much.
Thanks, Nancy, and to Anne and all the folks who contributed to that important work group. Next, we'll hear from Peggy O'Kane. She's the president of the National Committee for Quality Assurance and oversaw the deliberations of the subgroup on data flow, care coordination, and quality measurement. Peggy?
Thank you. First of all, I want to echo the other conveners and say what a fantastic group we had, and we had very lively discussions in our work group as well. One of the things that we discussed was the payment methodology for telehealth. And I think there was a lot of lively debate about this because obviously the context matters. I think it's my opinion and the opinion of some others in our work group that value-based care models really allow the greatest flexibility for telehealth to maximize its potential. That's partly because in a value-based care model, usually practitioners know who is really kind of watching this patient and making sure the right things are happening and the wrong things aren't happening. So that's a first point. Second, we shouldn't expect higher standards of care for telehealth, just as we shouldn't expect lower standards of care. So we need to adapt whatever standards or quality measures are to the situation, but we shouldn't set up different expectations. I just want to say, as a group that does a lot of work with quality measurement, NCQA very quickly moved this year to adapt 40 quality measures to allow for telehealth encounters to meet the requirements of the measure. So we're proud too of our ability to be agile about that kind of adaptation. Third, we think the platforms for telehealth, it would be great to have a certification program that allows people that want to install a platform to know what they're getting. And so that aligns with the 21st century, that would align with the 21st Century Cures Act and other care setting policies. We have had in this country, in spite of all the money that's been spent on digitalizing healthcare, we've had a lot of data blockages and things that don't allow information to flow where it needs to go in order to optimize the chances of having good quality. There was a lot of discussion about the opportunity that is presented to have a living care coordination document shared among all care team members, not just telehealth, and away from the siloed care that we often see in American healthcare. So again, I think integration, where telehealth permits greater integration of all care team members and a much more deliberate and strategic care management process, that is exactly the potential that we think should be maximized. And we also think we should pilot digital patient experience surveys that let us learn very quickly what's working and what's not working and for whom. So, different patients have different requirements. I think the market teaches us that you need to segment the populations you're looking at, and we need to learn rapidly. That's also true of practitioners. So different types of practitioners practice differently, and they will have different requirements of this. So we are embarking on a period now where, when we first rushed in because of the emergency, people did a great job in many ways, but now we have the opportunity to refine and really cultivate the models. I think it's a time others have called for shared learning, for research. We all want to emphasize the importance of that. So there's some we can learn from the early experience, but we need to learn as we move forward with these programs. Next slide. Frank?
There's just the one slide, Peggy.
Another one, okay.
And then Dr. Watson.
Okay, so I'm going to end now and turn it over to Dr. Andrew Watson from University of Pittsburgh Medical Center, who's been a pioneer himself in telehealth, and he's a great evangelist for the wonderful work that can be done. And because he's a surgeon, he sees this differently from other types of doctors, I think. So.
And thank you all very much, Peggy, for your kind words, and also Anne at the ATA, Krista at the ACC, and I have tremendous respect for the group that's been here and come together and issued this policy. And one of the areas that I think that we discussed was the taxonomy behind telemedicine. And it's interesting because telemedicine has a number of, it's multifaceted. There's multiple parts to it. And I had the, Anne and I spoke last night about this, and the ATA has a taxonomy that describes this, but just wanted to make a brief comment that telemedicine, much like we describe patient care or my own surgical career at UPMC, there's multiple aspects of the type of care we deliver, the types of surgery, and likewise the types of technology behind telemedicine. And telemedicine really is the all-encompassing rubric behind this. We saw in our world, telemedicine started at UPMC really in 2000 with behavioral care, and it evolved a lot. We saw in the country with the advent of live video visits really coming in full scale around 2015. And now we're seeing this tremendous boom of remote monitoring coming in 2018 and now beyond. But the rubric or the lexicon behind telemedicine really encompasses those as a whole. And we see a lot of evolutionary pressure on the field of telemedicine. I've used surgical telementoring, remote monitoring, and live video visits in my practice. And I use live video visits quite commonly in my practice as well. But we're watching the consumer electronics market with bioperipherals you can buy, blood pressure cuffs, glucometers. We're seeing new apps. We're seeing new capabilities of smartphones. The Apple Watch was released an app about a couple hours ago that now has pulse oximetry built into it. And so one of the points of this brief series of comments is just to highlight that the telemedicine and really the work that Anne and the ATA, and have been proud to be on the board there many years, have been leading, is that telemedicine really encompasses this as a whole. And this new player and this new incredible growth in remote monitoring is part of that. And the reason why this is so important is that, as Peggy pointed out, and Ann and I have discussed for many years, is that this comprehensive suite of technologies of telemedicine will have a significant impact on how we coordinate interoperability, how we look at data sharing and the new governance rules, how we look at flow into EHRs, payer care management systems, claims systems, what does patient-generated health data mean in the future? And really, are we getting to that point where the Internet of Things, a term that I usually try to avoid but will use, how does that truly encompass or impact healthcare as a whole? And so with this task force report, what we're seeing is an opportunity for this multi-dimensional aspect of telemedicine to really bring tremendous value to our healthcare system as a whole. And much like Nancy, UPMC as a payer provider, we're seeing it from multiple different venues. But overall, the technology really is a holistic offering with multiple facets. And so it's something we're watching in an evolutionary fashion. And COVID really accelerated our view in our understanding of this. So I'm just privileged to be part of this group and look forward to continue to advancing this on these discussions, chats, social media, and other forums as well. Back to you, Peggy and Frank. Thanks so much.
Thank you, Andrew. And thank you to Peggy and all the folks again who contributed to the data integration and quality measurement group. It was one I got to sit in on quite a bit and really incredibly rich discussions. I'll now take us through the overarching findings and recommendations. These were findings that came up in at least 2 and often 3 of the groups that we felt sort of rose above the buckets that we had put the issues into, but that were in some cases essential to those discussions and to the future of telehealth. And I think you've heard some of these raised, but I'll emphasize that they were prevalent across the subgroups. The first is the concern about access, trust, access to technology, access to broadband, and digital literacy gaps. The concern is that if we don't address these issues, telehealth will be just another part of the healthcare system that leaves behind some of the more vulnerable populations, including those in rural areas, lower income areas. Urban lower income areas have certainly broadband and access issues, as well as vulnerable populations such as those who are mobility challenged. So it's very important as all of these recommendations move forward and policymakers consider what can be done to maximize the benefits of telehealth, that these concerns be addressed. Secondly, and this is overarching in that it touches on issues raised in each of the subgroups, the task force is calling on Congress and states where it applies to permanently lift the telehealth restrictions on originating sites, clinicians, conditions, and previous clinician-patient relationships, as well as care across state lines, which again is a state-by-state decision. But lifting each of these and facilitating the care across state lines is going to increase access. As we've said, we've seen what that looks like in the 6 months under the public health emergency. And we believe that it offers a lot of promise, and that while safety and program integrity are essential, we believe these restrictions can be lifted almost universally without touching on those concerns. And where they can't be lifted universally, they should certainly be addressed and tailored to the concerns about safety and program integrity. And finally, on that follow-up to that note, we do believe that the HIPAA privacy enforcement that was suspended under the public health emergency for telehealth should be put back in place for obvious reasons. Now, let me turn over to Dr. Regina Benjamin. She's the former U.S. Surgeon General, excuse me. She's also the founder of the Bayou Clinic and the Gulf States Health Policy Center. And she will talk in a little more detail and in very, I think, personal terms about these findings and recommendations that reach across all three areas. Dr. Benjamin?
Thank you, Frank, and thank you everyone for allowing me to be a part of this group. It's been amazing to have those conversations, and hopefully people can understand how much went into this and the discussions that we had. One of the things that I have come to understand since COVID is that telemedicine and telehealth is now widely accepted. Patients value it, they expect it. Even my little elderly Medicare patients want it as an option. So it's not just another site, another type of care, it's just another site. It's like when I go out and do my house calls, I don't have to get in my truck, I can get on my iPad or I can get on my computer. So it's another site of care, and we should start to treat it that way. But I wanted to talk a little bit about the various challenges around access to care for different groups. And one of those groups was mentioned is the rural population, and that we recommend that broadband be strengthened, and that policymakers really make sure that these rural communities have access to broadband. But also, many of the patients I talk to with in the rural communities particularly, they may only have a landline, and a landline is all they have. And so I can't do a video call, but I can do an audio call. So we have to make sure that we understand that everybody doesn't have the same access to technology. When you do an audio call, it can't just be a call where you just call and say your labs are normal and hang up. This is just like any other visit. You do the history, the physical, you assess the labs, you document it, and the whole bit. But that's also addressed in our report here. There are patients who have visual and auditory challenges and mobility, as you've heard. But if you look at in your iPad, you can make your letters much larger and they can see them much better. And the same thing with hearing, but we also have to make sure that as we recommend policies that we include access to care for various groups, as well as various populations of care and various communities and different income levels. I'm particularly interested in those, in everyone, but particularly those who work for a living, don't have enough money to afford insurance, but they make too much for Medicaid. And they're what I call the self-insured, and some people call the uninsured. But we need to make sure they have access to telehealth as well. I'm here in Viola Battery, Alabama right now. We're expecting the eye of Hurricane Sally to hit us this afternoon. But I remember during Katrina, Viola Battery has 2,500 people, 2,000 lost their homes. And it was a time when we really needed technology and some way for people to have contact, and particularly for their safety. And if many of you recall back in that time, some of the telecom companies basically would give free phones and free minutes so people could have some emergency access. And they called them Obama phones in those days. But perhaps we need to make sure that all parts of the populations have access to some of this technology. And with insurance company, those who are insured, perhaps they can cover the phones and the iPhones and the iPads and other technology as a supplemental benefit, and that could be allowed. In addition, to those, I also want to make sure we talk about health disparities, because we have such health disparities amongst different populations. Telehealth can help us improve those by improving the access to care. A mother or a young mom who's working 2 jobs doesn't have time to take off and spend the afternoon coming to see me in the office or the clinic. She can make a 20-minute visit during her lunch break and get it taken care of. We can use remote patient monitoring, like some of the devices that was just mentioned, to maintain a good evaluation of the blood pressures, of their blood sugars, and monitoring them, ultimately leading to better quality of care and, of course, better outcomes. And hopefully we can decrease those health disparities. I look at this from the point of view of a primary care physician, and I try to look at it from the perspective of the patient and how the patient really, how it benefits the patient. And so for me, when I started doing this, I was like, this is really exciting with increased access to care. But I understand, particularly being on this task force, that insurers think of increased access to care as increased utilization. And yet I think that we have to find that balance between the two. But again, this is my perspective, and I think that by increasing this access to care, we will ultimately increase quality, increase better outcomes, decrease our disparities, and hopefully in time that our studies can show us that this will lead to decreased costs and improve the ultimate value to our entire healthcare system. And finally, the last thing I want to make sure that I don't forget is to say that many of the restrictions that were lifted during COVID were very good to be lifted, but we have to make sure that the patients are protected and that their privacy is protected. And so we're recommending that for now that HIPAA patient protections be reinstated after COVID is over, or we get through stages of COVID, but patients' information have to be protected. And we may have to adjust them in different ways, but we need to make sure that they're put back in place. So thank you for letting me voice those opinions, and I'll turn it back over to you, Frank.
Thank you, Dr. Benjamin. Thanks to everyone who's participated today amongst the speakers. It's been a great discussion. We do have a number of questions in the chat, and I'll go right to those. I'll throw them out on behalf of our audience members who've asked them, and then ask any of the speakers to comment if they would. Directly to what Dr. Benjamin just addressed, we have a question that asks, When do you think we can expect to see some permanent decisions or shifts in policy and procedures being made in the area, meaning telehealth policy and some of those restrictions being made permanent or not? It usually takes years to hammer out details. So does anyone have comments on the timeline for those types of decisions, either at the state or federal level?
This is Krista Droback. I would say that policymakers are definitely under a lot of pressure to create some permanent change. One of the things that's different today than 6 months ago is there's actually a large constituency now who have actually used telehealth and like it. So they're hearing from seniors, they're hearing from the traditional stakeholders that that we've had this major change and we don't want to go back. I think that's why this task force report is so important, because making long-term policy is a lot different than making policy in an emergency. So I think they were obviously willing to lift the floodgates in an emergency, but now we have to be very deliberate about what long-term policy will look like and protecting quality of care and taxpayers. And I think that this report will go a long way towards answering some of their questions and helping think through how to really do this right. So I hope that answers your question.
Great. Thank you, Krista. Let's see. Another question. Telehealth has been extremely helpful, but prevention, include preventive services, I think they mean, including immunizations, decreased during the pandemic. How are we addressing the impact of this? Peggy, you're on mute.
Let me take that, because this has been kind of an obsession for me personally this year. I think it's the responsibility of the system or the practitioners that are taking care of the patient to work with payers and local assets. I mean, many pharmacies, many supermarkets are giving, for example, flu shots. It's really important that if there is a telehealth encounter, that the patient is reminded if they're due for a shot. I particularly worry about children because we've seen the largest decrease in in-person visits during the height of the pandemic for kids. And so we know that measles is it's very, very highly infectious. We don't want to have a measles epidemic this fall or whenever. We want to make sure that the whole patient is being taken care of. That kind of reinforces the point that I was making before, is telehealth, it's not everything, and it needs to be integrated with the other sources of care that are appropriate to this patient at this moment. And somebody needs to be paying attention to the fact that the patient got what they needed. And I invited.
Yeah, Frank,
Go ahead,
I'd
Dr.
add to
Benjamin.
that, prevention and national prevention strategy has also been my whole platform forever. It's important that we continue to emphasize how important prevention is, and telehealth visits are one way that we can reinforce that need. Many of us, like what we do is we will say you need to have your flu shot or your vaccinations, and we'll set it up ahead of time so that all you have to do is come in, get your shot and leave, because everything's already coordinated once we do that through the telehealth visit. And that's made it much easier and much more, efficient for the patient. Again, looking at it from the patient standpoint, but we have to use whatever platforms we can to continue to reinforce the importance of prevention.
I just want to comment on the really thoughtful questions that are coming through the chat, way too fast for us to answer. But I did see a couple referencing the adjustments that have been made to quality measures to accommodate telehealth provision of some services. And I can refer you to NCQA's website, ncqa.org, to HEDIS. And I'm not clear about what others have done around adjusting other measures, but for our measures, you can go to our website. Thank you.
Great.
Peggy,
I'll give you from the list. We have a comment that says, like World War II, I think they're referring to health insurance, which really became prevalent during World War II as an incentive for workers. Telehealth is here to stay, Yahoo. So there's a little cheerleading from someone who's clearly happy with all the progress that's been made. Here's a question. Is it possible to deliver telehealth by telephone only for the long term? If that is the only option available, and should it be reimbursed the same as a regular visit?
I mean, I expect these kinds of questions to be sorted out over time as people study the effectiveness. And, you know, the prevalence of video today may be better, we're hoping. You know, I see some calls for assistance, you know, for government assistance to get broadband more widely available. I think that was a widely shared view with our group.
It was, and I'd also say that, you know, I mentioned it a little bit that some people only have landlines. And so once they do that, as a primary care physician, I put just as much time into a telephone only call as I do with one with the video. There's some things I can't do with just a telephone. I need to see. And so that's important that that's understood. So I'll have to individualize the patient. One of the, just anecdotally, is one of the things that I'm having patients say right now is, it's like we're on Zoom all the time there and I doing a video and they can't we just do this with the telephone and not have to turn that camera on? I'm like, no, we can't, we have to. But there's some things you can't do over just a telephone. There's some things you can't do just over video. Some things you have to do in person. And so we'll have to adjust them to each patient.
And I want to echo Dr. Benjamin's comments. As a surgeon, I do use a telephone, but I do prefer video. But, you know, she's brought this up and others have the bandwidth, as you point out, Frank, that there's bandwidth limitations. And I first met, you know, Ajit Pai at a conference that Ann held with the ATA. And, you know, the FCC and Ajit Pai have been very progressive in its grant funding and its work for supporting equity and broadband and looking at disparities in the United States. So he's a very good one to follow. Again, on Twitter is a good example, or another work that he does with the FCC. But I just want to call him out and thank him on behalf of our patients and the work that he's done.
We have another question. Telehealth platform certification is a great idea. How long would it take to implement? Who would own that? ATA, NCQA? It's important for payers to be able to begin expecting standardized delivery among the varying vendors.
NCQA is looking at that opportunity. That's all I could say at this point.
Sure.
And-
Dr.
and
Watson,
there
I know
are-
you.
Oh, sorry, go ahead.
No, Ann, please.
There are other accreditation programs right now for telehealth. And then of course there's NCQA, so URAC, JCO, so there are others that are available. The ATA as an association is not in the business of accrediting its members. Seems counterintuitive.
Okay.
Somebody said they're not getting the answers to all the questions, no written responses. We're not able to keep up with the flow of questions. So is there something we can do to kind of share some of, we're not answering all the questions that have been submitted in writing.
And they are coming in feverishly. So I think the best we can do is keep flying through them, and then we will try and triage and respond to those things that there's a particular.
Maybe we could do some like FAQ for questions.
Sure, and we may well hold another of these in one form or another. So please keep the questions coming. We will be responsive as possible. Where did the TTP come out on letting FQHCs and rural health clinics serve as distant site providers on phone-based audio? So those are two questions, I think. First is around FQHCs and rural health centers. And the second is on phone-based, which I think we covered a little bit earlier. Folks want to talk about, I think what we, in the broad overarching recommendations, we said that the restrictions on sites in general are arbitrary and overly restrictive. And so I assume that would apply equally to FQHCs and rural health centers. Anyone else have a thought on that?
Yeah, I mean, I think, you know, access has been such a problem in rural areas that I think some of the great promise of telehealth is to allow people that live there to access high quality services through telehealth. So our work group didn't talk in particular about FQHCs serving people that are geographically distant. But I think that was an understanding that that would be part of the benefit, but I don't want to speak for the other work groups if somebody had a different opinion. But I don't think we actually got into the specific question.
So we talked about it a little bit in our work group, but not a lot. But you know, I have a FQHC lookalike. I would think that the same thing should apply to FQHCs as any place else, because oftentimes they're in underserved communities. They're in places where you will have extra need, and so this is another tool, another way, another site to take care of patients, and another way to increase their access to care. So I would think, you know, we'd want to extend it to FQHCs and rural health clinics.
I just saw in the chat that Dr. Julia Skapik, who works for the National Association of Community Health Centers, said that there are sometimes restrictions on CHCs and that the NAC is working to get those restrictions eased.
We have a question. How can we balance interoperability and data sharing between telehealth and other healthcare providers while minimizing additional administrative burden on physicians?
I would like to take that. There was another one that said, how do we balance that with privacy? And I think we need to understand that privacy is not talking about information sharing between different practitioners that are taking care of the same patient. In fact, it's in everybody's interest for that information to be shared. So the burden part of it, maybe it's better to let one of the practitioners speak to that point. It is part of the job to coordinate with other practitioners.
It is part of the job, and as a family physician, I rely on specialists, and we do, you know, asynchronous transfers of information, you know, your x-rays, your labs and all of those things. And so we have to share that. But what we are concerned about with protection is that you don't allow patients' private information to be used for commercialization without their knowledge, without their consent. Those things need to be in place, and that people don't have access to them that shouldn't have it, and particularly without the patient's consent.
Thank you, Dr. Benjamin. Good point.
We have a question probably for our practitioners. How do we change the thought processes by the senior population to embrace telehealth? Working in population health, many seniors are reluctant to take telehealth visits.
I'm going to jump in again and say seniors have not really been as reluctant as I expected them to be. They've been the ones who are saying, I like this and I really want to keep doing it. What we do in our office is before the telehealth visit, is you get on the phone with them or get on the technology with them and make sure they know how to use it, or make sure they have someone in their home that can help them. And so we kind of walk them through it. Sometimes it depends on the visit, but if it's a day before, or even if it's just 10 minutes before, to make sure they feel comfortable using it.
I agree with Dr. Benjamin on that one. At Intermountain, we have about 5,000 patients over the age of 65 that are in our remote patient monitoring with video visit program. And actually our average age is about 76 in that group. And they love it. And they actually frequently request to have all their visits in telehealth rather than go in person. We have to encourage them to go in person. I think the ease of usability of the devices or the platform is really what hinders or helps a patient adapt to telehealth. And that applies not just to the elderly population, but to the young population as well. And so it's inherent upon us as deliverers of healthcare to make sure we're providing an easy user experience, regardless of age.
I just want to add that, and there's some comments coming through on the chat, I think the idea of seniors not being willing to use technology or telehealth services is increasingly a myth. There's a number of research studies that have come out. John Hartford published something early on that showed that people even 75 and older were willingly and happily adopting telehealth. So I think we assign it to the myth category.
I want to echo Ann's comments, and it's very true. There is some preformed notion that seniors don't use technology, and also what Regina said as well. And one thing that's very important to recognize with seniors is that many times they have caregivers that help them. And I don't think we know as an industry how much the caregivers are behind some of the adoption of telemedicine, but it's something we've certainly discussed a fair amount at the ATA, but many times it's invisible. But I know a lot of family members help my patients get on the technology and use it. But these days it's becoming so easy to use. It's, as Ann points out, it's a business assumption that I think is fading.
We're a little over time, but folks, because of the volume of questions, we're going to keep going, understanding if anyone needs to drop out. Here's a good cutting edge question that I know has come up in a lot of discussions. Will artificial intelligence become a useful or vital part of telehealth to obtain information and data prior to or in place of a practitioner speaking with their patient?
I'm a family doc. I don't want to be replaced. But I do think there is a absolute place for augmented intelligence, as well as, you know, AI, and to help us make this, you know, bring all this data together. We have so much data that it's hard for us to go through it all, and I think AI will be able to help us do that. And that's one of the things that we'll just have to see as it comes, but there is place for it.
Great. Let's see. We have a large group of seniors who are okay, we've got that. A lot of comments on the seniors. I think folks are happy to share that seniors are embracing this technology as much or more than other groups. Let's see. For those of us with technology skills that would like to participate in this movement, how can we get more involved? That's a very interesting question. I'm sure there are a number of ways. I don't know if our members
usually refer folks to their regional telehealth resource center as a place to start getting involved if they aren't currently involved with telehealth in that arena, because that loops you in with other local providers as well as gives you access to the national information.
Great. How do we balance antibiotic stewardship with telehealth? Anecdotally, many of us have seen widespread antibiotic use for ear infections, strep throat, and UTIs without examination or testing.
I guess I'll hop back in here and say at Intermountain, we ask that our antibiotic stewardship program apply to all virtual programs equally as it does to in-person. And my virtual urgent care, which is actually the largest urgent care in our system, has amongst all of our urgent cares the lowest rate of antibiotic prescriptive use. And we just adhere to the principles of antibiotic stewardship regardless of the modality of delivery of care.
And I would just add, Frank, that there was a study that was published recently by Children's Hospital here in DC National on antibiotic stewardship as well.
Great, thanks, Ann.
And Frank,
What is one piece of technology that could accelerate telehealth?
Inexpensive.
Satellites that circle the globe and provide internet or high-speed access.
I gotta say, I think the technology's there. It's policymaking that needs to catch up, and it will make it take off.
Yeah, I agree with that. Frank, there's one here that says, we found that much of the social determinants of health screenings have stopped when telehealth ranked up because of the workflow processes and screening. And I just respond to that question by just saying that we're, at our Health Policy Center, for example, we're applying for NIH grants that are out there around health disparities and social determinants. We're engaging the community health workers to start to collect a little bit more of that data using virtual visits, virtual iPads, that kind of thing, just to stay engaged in the community so that we can continue to screen for social determinants of health.
And along that line, Dr. Benjamin, I see one that says, how does telehealth accommodate non-English speaking patients? Again, this is something you need to pay attention with in the platform that you utilize. that you have the ability to bring in interpretation, and not only in non-English speaking, but remember in our American Sign Language patients that telehealth can be an incredible resource when you're allowed to bring in multiple parties into a visit that we can more seamlessly provide to those social determinant needs.
Great. We had a number of questions about teledental. I don't believe that came up in our discussions, but I'm willing to believe that several of our conveners or participants may have thoughts on that.
Well, I always have an opinion, but I think it's important to, you know, the dental care is very important to your overall health, and especially if you're in pain. Being able to have a visit with your dentist and them to give you some direction, some advice and things that, and then just if they have to schedule you to come in, you've done the pre-work to get there and they'll tell you exactly. So it's like triage, but it's also letting you know not to go on further, or that you can do some things at home. So
there's a lot that we can do these days also with peripherals. There are now peripherals that are becoming, as someone pointed out, much less expensive. We can actually better visualize the mouth, the teeth, the gums, and the like. I'm not sure we'll ever get to a tele-tooth fairy, but maybe that's a stretch goal.
Love the concept.
I like it.
Let's see. How can policy support small solo practices in adopting or scaling up telehealth?
I think that's where the reimbursement becomes important. The technology has actually reduced substantially in price. If we have adequate reimbursement to support service delivery, then it should be available to everyone.
Great.
I think you could really empower primary care, follow-up visits, and engage your patients in new ways with reimbursement. I agree with Carrie that reimbursement is such a critical piece of this, because why do telemedicine when you don't get paid for it, but you do if your patients come in? So if you're freed from that requirement, it seems like you could engage your patients much more deeply, more regularly, and improve primary care.
Yeah, exactly. I'm sorry, go ahead.
Yeah, I was in solo practice for 22 years, and I wish I'd had the ability to do some of this. And so it would allow, the technology allows you to do more in a shorter period of time and to be much more innovative. A lot of the follow-up calls and the things I would have to do at night after work, I could get some of that done, and we could get it done on a visit. I would just call and check on a patient. Now I can make sure that that patient is doing what they need to do. And these sort of things can help the practice flow better. I can be much more comfortable in knowing that I'm taking care of the patient and not wondering as much. For the office staff, it would be a much easier way for them to just integrate everything that we're doing into the overall care of that patient. And so I think it would help the solo practitioner.
Well,
Let me make this, sorry, go ahead, Carrie, sorry.
I was going to say, I think that this also reaches back to the issue of, are we looking at reimbursement based on value or volume? The fee-for-service model encourages volume and visits in order to keep the solo practitioner afloat, whereas in a value-based arrangement, telehealth is a natural extension of providing care.
That's right. And I was thinking, I wasn't thinking of the payment model as much as from the patient perspective and the quality perspective, but we will have to adjust that payment models, because the current one, it doesn't fit into our future in this digital world.
Great. Let me make this the last question, and I think plenty of folks may have answers, but Krista and Carrie in particular. Can you point academics and other policy wonks towards high quality data sets that reflect utilization trends during the pandemic? Your thoughts on that? I know that's emerging by the minute, obviously, because we're still in that pandemic, but thoughts on where they might go or what might be coming?
Yeah, thanks. I'm going to plug Krista's team. The Alliance for Connected Care has some excellent resources associated with that.
It's on the Taskforce page of the Alliance website under resources. To be honest, it's like the most unscientific data gathering ever. We just called everyone we knew and asked them to give us a chart. So those are the 20 charts we got, and we continue to do that. I even went as far as posting on LinkedIn when people give us data. It's very difficult to get data, but I know that ARC and PCORI and some of the other government-funded research organizations are commissioning studies that I'm assuming will be much in our data gathering effort.
Great. So stay tuned on that, certainly. Let me say thank you to all of our speakers today, to all of our audience and the great questions you've had. We're going to do our best to respond to those we can respond to, but we really want to make this an ongoing dialogue. So we hope you will you will be getting information about the report itself, and then some other follow-up information, including the slides. So keep it coming. ncqa.org/telehealth for us. The Alliance and ATA are out there, and you can obviously reach to them as well. We're really grateful for this discussion, and we hope it's the beginning of a long-term move towards permanent and successful telehealth policy. So thanks, everyone. Our moderator has some closing, or our technical assistant has some final comments, if you could.
Ladies and gentlemen, that concludes today's webinar. The report and the speaker slides are now posted for you to download at ncqa.org/telehealth. A recording of this event will be available online within 24 hours. Thank you for joining us, and have a great day.